realizing that we've had it all backwards, and that it would have been nice in medical school if we had had a conversation about, here are the emotions you're going to face when you're looking into the eyes of a 25-year-old male who was flown by helicopter into your intensive care unit with a post-viral cardiomyopathy, and you will be resuscitating on his way to the operating room for an LVAD. That was one example where I had no idea I'd be facing that as part of my training. And I just would have wished that someone might have prepared me to deal with the emotions that came up.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. My guest on today's show is Dr. Jonathan Fisher. And Dr. Fisher actually has a very interesting title and role in his organization. He is a clinical cardiologist and a clinical physician executive in organizational wellness and resiliency team at his organization, which is Novant Health. You know, it's an organization spanning 4 states and has 2,500 physicians and close to 40,000 employees. So it's a big organization, and to be in that leadership position with 2 other physician leaders in what is becoming an extremely important area of organizational wellness and also development and leadership, and he's going to talk to us more about it, is, you know, mindfulness and wellness and resiliency, because as we know, burnout is the new epidemic that is afflicting and affecting, you know, our physician colleagues. So with that introduction, Jonathan, welcome on the show, and thank you so much for doing this for us.
Ankur, thank you so much. It's really a pleasure to be here. And when you invited me, knowing your background, your history, and the work that you've done in the world of cardiology, which is my home, I jumped at the chance to get to talk with you. So thank you.
Oh, no, my pleasure. I've been following your posts on LinkedIn for the vast majority, but also Instagram. And I know that you have found an important voice in this area of physician wellness, which I think is at the crux of many organizations now, rightly so. It's found a spotlight for itself, and it's something which is important, obviously, because it is tied to outcomes. And, you know, you'll obviously go over this with our listenership, but I think if the physicians are feeling, you know, depressed or angry or burnt out, it affects how they show up at work. And if it is affecting how they show up at work, it is going to affect how patients are going to get treated and what their outcomes are going to be. But do you want to talk to us a little bit more about that?
Yeah, of course. The reason that I'm interested in this area of wellness has nothing to do with medical school or training. You know, when I was a medical student at Mount Sinai, no one discussed well-being or the mental health, emotional health, the life satisfaction of the physicians or the students at that time. And certainly when I went up north to train at the Brigham, that was never discussed. It was purely about the practice of cardiology and the science of cardiology and the art of cardiology. And so I guess I was operating under the idea that if I just worked hard enough and I followed the curriculum, I would end up with this wonderful career, and I would get to help people and help the heart. And yet there was this slow, insidious downward spiral that was happening even as I was going through medical school, beginning with spending 3 months on neuroanatomy without a single conversation about the deeper meaning of what it means to be inside of the body, to be exploring the connection between the mind and where was the spirit after the body was gone, and deeper questions, philosophical, existential questions. And then as a resident, facing lots of patients, young patients with cancer, with heart disease, cardiomyopathy, who were dying. And I had the most amazing residents and fellows and attendings who taught me what I needed to know about the heart, but I learned zero about how to bear witness to tremendous suffering. And what I didn't realize is that I was deeply empathic, and that my natural extension of empathy for these sick patients was to feel their pain myself. And I have a sense that I wasn't alone in my sensitivity to this, though I guess it's not the typical cardiologist who may experience it that way, which is why I'm attracted to your work. So this is the beginning of my own journey, was medical school, residency, fellowship, and things kind of went downhill from there, relating to my own anxiety and depression, which was undiagnosed. And the reason I'm sharing that now is specific and strategic, and it's to let our cardiology fellow colleagues know that it's okay to not be okay. It's okay to be going through these things. And frankly, I went to therapy in secrecy, all during my residency training. And so what I realized that after doing lots of work on myself and spending about 10 years deeply exploring Eastern traditions and mind-body practices and Western psychological, psychotherapeutic techniques, all while I was doing my cardiology practice, I realized that as I was sharing my own journey, my fellow cardiologists were kind of leaning in with curiosity and saying, "What's going on with you? We've noticed some changes." And I began to share. And I'll pause right there, and I'm happy to jump back into the narrative wherever. But my journey of discovery began over a decade ago, and I started presenting my findings in 2012 on a subject that very few people were speaking about, which was the connection between mindfulness and cardiovascular health. And I delivered a grand rounds a decade ago on that subject.
Yeah, so, thanks for sharing your own story, and thanks for the vulnerability, and thanks for being open about it, and also, using your pain for a higher purpose, and that is to usher in organizational change and affect, your peers and colleagues. I think it's an extremely important area, which, requires further attention. It actually requires further systematic investigation. But, if we just to step back a little bit, what were some of the changes you were observing in your own inner self, through medical school, residency, and fellowship, as you described? Because it was you mentioned, and you described it as an insidious downward spiral. So if, just for someone who's listening who may be going through what you went through early on, and want to identify with those feelings or with this phenomenon, how can you describe what you were feeling?
Yeah. When I look back, I remember myself as a very diligent medical student, really trying to get, honors in all of my rotations. And so learning to mirror and to mimic my residents and fellows and sort of follow what they were doing. And the example that was set for me, I didn't realize it was unusual, but the example was to not pause, to not sit down and take a break and a deep breath, to not tell a story and have a laugh, and also to not even stop to go to the bathroom when we needed to. So at the beginning, there was this slow ignoring of basic bodily functions and basic human needs for connection, for rest, relaxation, and nourishment. And the hours were long, and call nights were particularly brutal. So I, in retrospect, realized I was suffering from sleep deprivation over the period of days, weeks, and months, so that I was almost feeling like a soldier in the barracks, where I had this attitude, which went from I'm excited to be a doctor to care for others to if I can just keep my energy and alertness up through this day, I will get through this day. And in the best case scenario, I won't hurt anyone, and I'll perhaps help some people. But over time, I realized that what was best about me, what had been my greatest strength, which was empathy, curiosity, and kindness, and the ability to communicate clearly, were really not prized at all. So I remember in medical rounds where what was really important was, could I memorize every word of my presentation? Could I get all the details straight? But there wasn't any celebration of what I thought was my job, which was to connect on a human level with our patients. And so I began to conform to what was expected of me so that I could excel and I could do well and hopefully advance to get a higher degree and go to a reputable institution. At the same time, I realized that my exemplars, the attending physicians who were absolutely brilliant, some of them were incredibly kind and empathic, and I really kept an eye out for that. but there really was an emphasis more on the cerebral aspect of practicing medicine and the academic side as opposed to the human side. And so I kind of was left with these emotions of confusion, not knowing what to do with my emotional heart as I memorized more. And over time, I started to lose my spirit of why I went into practicing medicine in the first place. And it became very mechanical, almost robotic, going through rounds, going through the motions. I remember how proud I was when I was a resident, and I had all the checklists, and it was almost a game. How many check boxes could I have for each patient? But looking back, that had so little to do with the art of healing, which now, as I'm entering the second half of my career, I'm realizing that we've had it all backwards, and that it would have been nice in medical school if we had had a conversation about, here are the emotions you're going to face when you're looking into the eyes of a 25-year-old male who was flown by helicopter into your intensive care unit with a post-viral cardiomyopathy, and you will be resuscitating on his way to the operating room for an LVAD. That was one example where I had no idea I'd be facing that as part of my training. And I just would have wished that someone might have prepared me to deal with the emotions that came up. Or the 35-year-old woman on my oncology rotation in fellowship, in residency, who had a metastatic breast cancer to the brain. And my rounding with her each day was a direct mirroring of my best friend from college, whose mother was just diagnosed with a metastatic cancer. And so I had no one to talk to about these very confusing emotions. And I did what I knew how to do, which was to put them aside and stuff them down, and to double down on my working hard and paying attention and putting on a good face. And over time, what happened there is that created an internal disconnection in my own lived experience. On the one hand, there was the physician who was showing the outside world what a physician was supposed to be at a Harvard hospital. And on the other hand, this deep wounded part of me was being walled off with these just layers of bricks that I was building slowly to keep them from coming up. And often I would act in maladaptive ways. So I would spend, I would go shopping on the internet, or I would just spend time by myself, hours by myself, and avoid other people. And just at the moment during my training when I needed more social and human connection and to express myself, I had no outlets, and I kept myself alone. And that cycle continued to the point of real anxiety and eventually depression. And then when I became an attending physician, I entered the world of organized medicine, working in a large healthcare system where I found myself with an email each week showing exactly where I fit on a graph of RVUs. And as it turned out, as a non-invasive cardiologist, I was dead last at a group of about 60 cardiologists. Though my patient experience scores have been in the top 1%, my revenues didn't match that. And I just began to question what this was all about. What was the point of this anyway? And so I had deep, real sense of forsakenness of my own life. And those were some of the changes, Ankur, that were happening while the outside world had no idea. I kept it to myself.
So much of what you just answered resonates, with me in person, but also, resonates with a lot of physician colleagues that I know who struggle with, the emotions that we see at work each day, because of the field we're in. We are meeting patients when they're at their most vulnerable, and they're going through turmoil either themselves or for their loved ones. I mean, I had this experience of being a patient myself when my son was operated last year. I actually ended up penning down what I went through as a father who happened to be a cardiologist. TCTMD was gracious enough to publish that as a blog. And then, just getting back to your, comment on organized healthcare and metric medicine is what I call it, is, every interaction that we have as physicians with our patients becomes a data point. And It is, relayed to us in the form of, metrics and work RVUs and, our efficiencies and slot utilization.
Mm.
And then you start to question as to why you entered, healthcare and medicine at the first place. And those questions resurface, and you sort of try to rekindle with your original self as a teenager or someone in high school who was inspired to go into medicine, to touch lives, make a difference, be emotionally present for your patients and their loved ones. And when you sort of meet the modern face of healthcare, and I don't know if it's a US phenomenon or if it's something which is global, but there are global burnout rates, and maybe you'll talk to us more about that. But I think what you are bringing to the fore is crucial for how we identify with our own selves when we see ourselves in the mirror each morning, and what we interface at work in terms of the metric report card that we are handed over, maybe on a monthly basis or a weekly basis. How did you communicate that to your organization, and how your own experience is now manifesting in what you are discussing in the C-suite or the boardrooms, as a person who's involved with organizational wellness and resiliency?
So I wish, Ankur, I could say that I was an assertive young physician, and when I witnessed organizational practices that dehumanized and at times humiliated the doctors who were sacrificing their lives, that I stepped forward and spoke bravely and clearly in favor of change. But that's not what happened. I was swimming in this environment that really, I'm going to say, is designed. Some of the structures and systems we work in are designed to remove the humanity of those who operate inside of it. And I don't mean designed in a nefarious or malignant sense. Often it happens unconsciously through the basic capitalist structures and the business school training that many healthcare leaders are given. And I think that healthcare is different than most other industries in that those that rise to the ranks of leadership often are the ones that have zero training or experience in the very practice that the organization is stewarding. And so I responded by keeping quiet, which was my default behavior when I noticed that I was being measured. And I may have spoken up once and said to a colleague, when my name is visible at the bottom of a list of 60 of our partners as being the lowest earner, it feels wrong. It feels like it's punishing me in a way. And I was told that this is what they found motivated physicians to work harder. And for me, in retrospect, that shows a real lack of understanding of how people are motivated, because high achievers are not necessarily motivated by made to feel bad about themselves. There are other ways to motivate high achievers, which we can get into later. And so the change at the higher level really happened much more slowly. And I realized that I wasn't going to change the system. And this is something I'm sure you hear, and I hear all the time when I speak to thousands of physicians in systems across the country. And even last year, I put on the world's first global summit on ending physician burnout. And I had representatives from 43 countries. Over 1,000 people were there. So I got to hear the stories that what I thought was unique about the California hospitals and the Maryland hospitals were really the same as in Saudi Arabian hospitals and in Kuwaiti hospitals. The way that doctors feel around the world, and APPs and nurses, is really agnostic to what country you're living in. There's something about the way healthcare has been organized. And some of this relates to organizational design in general, which is still in evolution. We forget that, modern industry is less than 150 years old or so. And the models of business in the West lately have tried to emulate the Japanese models, leading to lean thinking. But as in so many cases, healthcare industry is about 15 years behind other industries. And so I don't believe we've adopted some of these best practices. And so where I am today is because of my own initiatives and my own work, which was done after hours for a number of years, giving presentations in shadowy rooms, leading stress reduction workshops, and beginning to speak out on social media about what I was personally experiencing, realizing that my only power was my voice, and that this shy, introverted person who was not comfortable speaking up in a group, if I was going to live any kind of a life that I had dreamed of, that I would respect, I would have to discover my own voice and be comfortable saying things that were uncomfortable. And as I was doing that, others in my field, in my institution, were listening, and I began to become invited into conversations. Not because I was argumentative, because I'm typically not because I'm confrontational, but I think because I am able to take the perspective of the suffering physician on the one hand, and on the other hand, bring deep empathy to leadership and to executives and managers, and realize that it's not an us against them, as so many of my colleagues have communicated through the years. It's that really pernicious attitude that many physicians have and many executives have, that we are fighting each other. And I think in my own studies of communication and negotiation, that it's only when we can get past those barriers to seek common ground and to really hold empathy for people that we might not have been sensitive to in the past, that we can sort of begin to co-create a new reality for healthcare. And then I was invited into larger and larger conversations, and eventually invited to do work 2 days a week on the organizational well-being and resiliency team, which is, I'm proud to say, one of, I would say, the top 10 such teams in the country in healthcare in terms of programs and initiatives. And that's thanks to the work of our Chief Wellbeing Officer, Dr. Tom Janicki, who had this idea 10 years ago, before we were talking about physician well-being.
It's terrific, what you just said. And, to think that modern healthcare design is, just 150 years old and is still in evolution, is when you put it in that terms, and you give it that age, obviously us in medicine knowing how evolution occurs. And I mean, it personally was enlightening to me that it's a very young system, and it's still in evolution. And, the evolution will happen through trial and error. And I think it's important for us to, have that reflection, self-reflection of how we're feeling and what do we think about the system that we're in, to usher in change. And, I really congratulate you for the courage to be vulnerable on social media and finding a voice on social media, and, sort of becoming a catalyst for change in your own way and, in your own world. And then, obviously what you were saying was resonating with colleagues and health and some of the healthcare leaders, across the boundaries and globally, that you had enough traction to organize the summit that you did. So, congratulations to you for the work that you've done. And I'm going to, utilize this as a segue to get into what are some of the conversations that you're having with, your physician leader friends at the organizational wellness and resiliency team at Novant Health.
Yeah.
And how have you utilized some of your own experiences in pain to usher in change for a higher purpose, which, clearly you're on a path to what I would interpret as spiritual higher purpose. I mean, I've written about spirituality in cardiovascular medicine, let alone medicine, and also, trying to sort of learned from what my spiritual text, which is the Bhagavad Gita, has taught us 5,000 years ago. It's more a way of life than a text which may be associated with religiosity. And I've sort of written about that in the European Heart Journal, and you've been very complimentary of some of these works that I've published. So thank you for that. But getting back to my question, how are you having these conversations in your organization, and what are some of the steps that you're taking?
The way I think about having conversations at an organizational level, and really I've had to reflect on this because, as you know, it's not part of the medical school curriculum. And like many of our colleagues, I haven't gone to business school. And so the way that we approach it is really like any conversation. It has to begin first with listening. And I think part of the problem, if you call it that, what's the last decade or so, is that physicians and nurses and providers have just been destroyed emotionally and physically because of a lack of listening and a sensitivity to what we've been going through. So the first thing we do in these conversations is we say, how can we listen, but listen at scale? So a conversation in an organization is really no different than conversations among individuals. You have to frame the right questions, first of all. And the questions that we ask have to be questions that don't seem gratuitous, unnecessary, rhetorical, like so many surveys. Every organization now hopefully has some kind of a survey instrument that's being used to get a sense, to take the pulse, to check the temperature, whatever metaphor you like, of how people are feeling. So it begins by listening, and that's usually, in our organization, we have created our own metric, but the key is not to spend too much time, making sure that you've picked exactly the right metric. It's just to get started with the intention of asking questions that will lead to real change. So and I think there have been studies on metrics in healthcare, and I'm sure you know some of this data, that at least 50% of the metrics that organizations are tracking are clinically irrelevant. And so we're trying to ask questions like, what is your level of anxiety? What is your sense of well-being in your life? What is your sense that this organization cares about you? What is your sense that your colleagues and your boss, if you will, have your well-being in mind? So really basic questions, and then taking that data in and feeding it back at scale to leaders of the various service lines and showing them what they didn't already know. We all have blind spots. We have our retinal attachment, where we all have a blind spot that we would never know about until someone showed us. It's the same thing in each department. And so the head of cardiology might not realize that half of her team members are thinking about getting another job in the next few years. So that would be a question to ask. So that's the first step, is listening. Along with that, at the same time, in a good conversation, it's also empathically communicating. So it's speaking to you in a way that shows you, I first care most about your pain and your suffering and alleviating it. And this is just as I think doctors are well positioned to be part of a large organizational conversation, because we really come to this from a place of empathy and wanting to alleviate suffering. And part of what I do is I use language that shows that I have been there and I continue to be there, and I continue to take overnight call, and I witness what happens. So there's a listening, and then there's an empathic communication that I am with you and I hear you and I care about your suffering and I'm committed to doing something. And then it gets to interventions. So, there's broadly speaking, two aspects to the burnout crisis. Burnout is not due to deficient resiliency. And there was a broken model of helping physicians for a few years there, where it was about, buying pizza and having yoga class and a little bit of meditation here and there. And I think that even mindfulness and meditation was misapplied for a number of years there. And so what we know now is that anytime we speak to providers, we have to frame it in the context of a broken system. And not to say that the entire system is broken, but at least to acknowledge that the primary drivers of burnout are systemic in terms of lack of autonomy for the people doing the work, a lack of flexibility in our scheduling, a burdensome, clerically heavy EMR system, a lack of a sense of support in the office, and lots of obstacles. So framing the interventions in terms of there are organizational, operational changes that need to happen. Those are top priority. And this is where the conversation also often goes off track, physicians, typically the ones who are already burnt out, say, don't help me, don't tell me how to help calm my own nervous system and to communicate more effectively, because you're blaming me when you do that. I want you to focus on the system only. And I feel like we're throwing the baby out with the bathwater when we do that and we take that approach. We're losing out on a lot of potential avenues to help really suffering providers. So we have sort of two arms. There's the operational reform arm, looking at finance and scheduling and staffing, and we have a cutting edge IT leader who's a physician herself, who's working to reform our EMR system so that it's user friendly. And on the other side, we look at how can we support our individual providers, regardless of what place on the spectrum of complete burnout to wonderful human thriving they are. And there are, currently there's between 50 and 60 initiatives that we have going on at any given time across an organization with 38,000 employees. And these are programs for physician executives, other leaders, nurse leaders, APPs, et cetera. And they range from, last week I led a session on self-compassion and its scientific benefits. Next week, I'm speaking about a mindfulness practice across all aspects of healthcare, including patients, physicians, and executives. We have a robust coaching program, which is offered to all of our providers, anywhere from a half a day to a 3-day offsite retreat for anyone who's interested. So the specifics are fascinating and they're fun to look at, but I've tried to paint a broader view of how we go about looking at where the pain is, looking at ways that we can rapidly, efficiently alleviate the pain. And then the last piece of this puzzle, like any good scientist, is look at the data. What is the measured impact of each of these initiatives? What is the cost? What is the return on investment? And ultimately, as you referred to at the beginning of the conversation, what is the impact on these initiatives on downstream measures of patient safety, patient experience, physician experience, outcomes, and the financial well-being of the institution?
Yeah, we have fascinating work, and I'm almost tempted to ask you if you have, a sneak peek into some of the data that you may have accrued through the initiatives that you just described. But, I think of the several that you educated us on, the one that particularly piqued my interest was the retreat. And, also to the comment that you raised, which actually is a comment that I've heard from several physician colleagues is, just don't tell me what to do, or, don't tell me what needs to be done. And you clearly know that is an upset colleague who is upset at the way the system has treated him or her, and is upset at the clunkiness of the electronic medical record, and is upset at the millionth click that we have to participate in or do in order to get the work done. What have you learned in your experience rendering this work, not only amongst physicians but amongst allied healthcare professionals and other employees in a healthcare organization? I'm genuinely curious.
So there's so many aspects of the experience of the physician that we're interested in that we can speak about. And when it's physician, I'm referring to all providers and all team members. And what I've found interesting is that we can't do this alone. So if you're interested in well-being and metrics, we have to have people on the team, and we do, who are experts in data science and really slicing data across all job families. And there are dozens of different job families across any healthcare institution. And it's not enough to say, what is the level of burnout among our team members? You have to say, are you a doctor? Are you a nurse? What region are you working in? And then breaking it down further, we know that Medscape and other surveys have done this well, saying, what's the difference between our male employees and our female employees? And how about those in the early, mid, or late career? because the interventions that are offered cannot be a one-size-fits-all. And the career needs are highly dependent on where cardiologists and others are in their career, in their trajectory, and the supports that they need are going to change over time. So in terms of what we've noticed on the measuring side is that burnout rates are high in our institution, as they are in every institution across the country. In terms of the next question is, so how many of our employees and your employees will actually utilize the programs that you offer? Because as you just referred to, the instinct is to brace yourself and say, this is a bunch of nonsense. I don't want your help. I just want to see change. And so what we're seeing is that the rates of utilization of our initiatives are higher than national average. So if you ask any physician in the country, it might be 10 or 20% say that their organization has meaningful initiatives that are really trying to help them. And our numbers are north of that. And then you were interested in the retreat. What we know is that physicians who come on retreat, and we have narrative data and we have also numerical data that show the majority have an experience of a life-changing turning point, where many of them are on the verge of either leaving their career or leaving this job. And at the end of the 3 days, they've had some deep insights into their habitual patterns of reactivity, of behavior, and they've been able to reconnect with their deeper sense of purpose. And there's ample data showing that the coaching model that we use, and this has been published in our medical journals, is effective at helping physicians through burnout, even while organizational change is happening. So it should not be an either or, it's a matter of both. And those now over, I think it's 1,000 or 1,500 who've gone through the program in the last few years, have the highest rates of job satisfaction in our organization. And this is, again, not as a result of working in a different department than their colleagues, but simply as a result of going through a powerful experience in a supportive environment.
This is extremely fascinating, and thank you for sharing that with us, and also thank you for the work that you're doing. I'm almost enticed to look at some of the short-term, medium-term, and long-term data that you accrue, through the interventions that you're conducting and carrying at your own workplace, to see if we can emulate your practices at institutions across North America or perhaps across the globe. Because you mentioned that this phenomenon is agnostic to geography. It's as much a phenomenon in Saudi Arabia as it is in Kuwait and other countries as it is in the US. And trying to summarize what we've learned and just getting to some of the important closing remarks, if you may, for the topic that we've discussed, and it clearly is a very, very important topic for anyone who's interested in organizational psychology and organizational leadership, and particularly wellness and resiliency. Before I ask you to share some of the closing remarks with us, I want your perspective on the term resiliency, because I know for many it's viewed in an adversarial connotation. So maybe if you could share with us what you think is resiliency to you, because for some it could be that I suffered tremendous hardship and tremendous bullying or harassment or moral erosion at work, and hey, look, I'm still alive. I haven't committed suicide, and that's resiliency. But obviously, there's more to it. So, what is your perspective on resiliency?
The first time I heard the word resiliency was a few years back in my own institution, and I saw that they were offering resiliency training, and I think the coaching retreat that I was referring to even was referring to that, and immediately I had a visceral reaction of disgust and anger. That I was being told in a way, it was suggested somehow that after 20 years of training and sleepless nights and sacrificing, my young marriage and my children in favor of my career, that I somehow was not resilient. It was the bitterest pill. And so I knew that in my own work, if I was going to step into this arena and to develop a voice, I was going to have to speak to that and help reframe the language in the conversation. And so I can tell you my own thinking about resiliency. If you look up the word resiliency in the dictionary, there are two definitions which I think are horrible, and most doctors are currently abiding by without necessarily knowing it. So you alluded to the first one, resiliency, the idea that you make it through an incredibly challenging time and you make it through and you just tough it up. And so that's one definition of resiliency. The second has more to do with a sense of flexibility. So if I throw a challenging patient at you, you can kind of do a little bit of Aikido and you can figure things out and make it through a very difficult situation and bring the patient through with flexibility. The better definition, I think, is neither of those. It's neither a simple flexibility and a bouncing back to where you were before, your baseline, nor just a toughness, which is look how straight I can stand despite being knocked down so many times. And it really has to do with aiming the bar much higher for our lives, and aiming the bar as high as having a life that's as full and as rich and as spiritually satisfying as any life could ever be. And you may say, this guy is living on a cloud. What does he think? Now, this is aspirational, but part of what happens to physicians, and we didn't discuss this before, during our training is that our hope is eroded over time. Our hope that anything will change in the system, which seems very inhumane. And we develop what Martin Seligman, who was the father of the field of positive psychology, called learned helplessness, almost like dogs who've been tied down for so long that when an electric shock is delivered, even if our leash is removed, we fail to jump because we forget that we even have a choice and any autonomy. And that's what I felt like when I first read that research. I recognized myself in it. And so this is really to say that my message is that we need to have hope as physicians, number one. If we want change to happen, we have to also look at ourselves and our own difficulties and how we put ourselves forward and how effective we expect to be in making change if no one is listening to us. So if I come at a system with nothing but anger and rage, which is reasonable, and yet I don't know how to play the game of business and conversation and negotiation and finding win-win solutions, I really have very little hope. So my message is to help physicians ground themselves. And I have this next year, we didn't talk about it, but next year's initiative, which I just began, is a year-long, week-by-week training and curriculum in the science of total well-being, just for physicians and providers, going through the science of positive psychology step by step in a serial manner, teaching the practices of mindfulness, self-compassion, and teaching the basics of empathic and effective communication so that all of us can have the same tools and be on the same page in learning how to make the change that we so desperately desire.
Jonathan, this is fascinating, and I can tell you that we've only barely scratched the surface, and I'm probably going to have you back, as a follow-up of some of the many important, insightful concepts that you've introduced, on self-compassion, particularly for physicians, and what that is and what that sounds like and looks like, and also mindfulness. But again, thanks for sharing your story with us, and thanks for sharing the kind of work that you're doing in your organization with us. And more power to you. And hopefully we can usher in change, which is much needed and required. And in doing that, you'll not only help physicians and providers in your organization, but also, nationally and across the globe. So I really congratulate you for what you're doing, and, also congratulate your organization in identifying you as a champion for leading this charge and this change. And
in the meantime, let's all stay connected on social media. LinkedIn is really my primary home. So if anyone wants to say hello there, I'd be happy to speak to you. And if you want to join the community, it's a group on LinkedIn with over 1,300 members. It's called Ending Clinician Burnout Global Community. And all of our events are announced there. Instagram as well.
Yes. And, Jonathan, thanks again. Great conversation. And, for our listenership, please drop in your feedback. I personally read all the feedback that we receive, whether it's through email or through direct messages, or on Twitter or on Apple Podcasts or SoundCloud or Spotify. This is obviously very meaningful for us as we continue to develop and get guests like Dr. Fisher on the show who are doing incredible work, not only in medicine, but also in the space of how medicine is delivered, how physicians feel. Again, physician wellness is crucial and important because, if you take care of the physician, then, obviously it's going to have ramifications on outcomes. And, all of us, myself included and Dr. Fisher, we went into medicine to usher in, wellness and health for our patients. I think if we can extrapolate that to our own self and our colleagues, that's obviously an incredibly important work. So, Jonathan, thanks again.
Thank you so much, Ankur, for all you do and for having me. Thank you.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.